So it's my pleasure to introduce Dr. Peter Schallett this morning. He's the medical director of the Swedish Medical Center's HIV program in Seattle, Washington. He's also a clinical associate professor of medicine at the UW and medical director of the Fred Meyer Pharmacies. Oh, I didn't realize that. Okay. He got his MD from the University. All right, we're a little loose this morning on Friday morning. Got his MD at the University of Washington, the PhD in genetics from the University of Washington in Seattle. He attended the University of Washington Medical School and got a residency at the University of Washington. He's board certified in internal medicine and is a member of the American Academy of HIV Medicine. So, as you probably know, pharmaceutical sponsored talks are not allowed to be given CE credits. However, I know that the information we're going to hear today will be quite valuable, and we welcome him. So, Dr. Schallett, take it away.
Thank you. I turned it on. It's working, right? Can you hear me? Am I mic'd?
I think so. Yeah.
Can you hear me back there?
Yeah.
Cool. So this is kind of a semi-informal talk. There's no slides. There's no PowerPoint. You just have me doing my little stand-up routine here. But please ask questions, pipe in if you have opinions about what I'm saying. The way this presentation is organized is through cases, but there's a couple of kind of important threads, and one of them is about how we manage the antiviral therapy for our HIV patients in 2015. The other really, and that's probably why Tara, thank you, and Merck sponsored this, is we're a lot about a kind of drug called integrase inhibitors anymore for HIV. We have a lot of classes of drugs to treat HIV, but integrase inhibitors are the newest. They've been around for less than a decade, and they've kind of taken over as a preferred class of drugs. We have these guidelines for treating HIV, which now greatly favor integrase inhibitors to be used when we can. Maybe a little bit more about me, too, before we start, so you know who's talking to you. So I'm a general internist. I'm not an infectious disease doc. I do primary care for folks with HIV and without HIV. I'm a little bit of a maverick practice-wise because I'm not part of a big system. I'm actually in an independent practice with another doc and a PA, and I'm too old to change that now, so that's going to be the way it's going to be as long as I can do it. I also want to kind of give you a little bit of context about HIV care and what I do, and those of you that have observed the field of HIV over the past few decades. It's been a really remarkable transformation, and for me as a provider, it's this amazing blessing that I've witnessed, which is that when I started practice in 1990, right out of residency, and I took over a small practice that was already doing some HIV care. And for the first several years of my work, really what I was doing with HIV patients was palliative and hospice care for people who knew that they were going to die, and that they were going to die a really horrible, ugly, painful, humiliating death. And it was very hard not to get burned out. People were really sick. I had this little ritual every time somebody died just so I could get through it. And then what happened was we started having treatment that actually worked, that actually suppressed the virus to the point that people no longer got sick. People stopped dying, and now the health status of most of our HIV patients is really indistinguishable from the health status of our HIV negative patients. And instead, their needs are the same needs that everybody else has as far as they get older, people pick up the diseases of aging, people pick up things like diabetes, hypertension, hyperlipidemia, other sort of normal life problems. But the HIV side really is more about managing the antivirals, making sure that they're not causing problems long term, making sure that people are tolerating them, and that they have as little impact on the person's quality of life as possible. We've been aided by the development of new drugs, which is continuing, And another thing that we do in our practice is we participate in multi-center trials for new drugs. So we get experience with them as they're in development. But I can tell you there are still a number of new HIV drugs still in development. It's not over. It's not perfect. And each year we have maybe a little more options, and each year maybe one or two of the drugs that we used to rely on kind of falls by the wayside because it's maybe not quite as good as some of the newer things. So that's kind of the context in which this presentation will unfold. There are 4 cases, and so these are all cases of people with controlled HIV on treatment, and the question, the issue for the provider is, should their treatment be maintained the way it is, or should it be switched to something else, or may it be switched to something else? It's an interesting question when somebody's on HIV treatment and it's working, and some of it depends on the philosophy of the provider, and some of it depends on the philosophy of the patient. There are some providers who feel that, who like to say, if it's not broke, don't fix it. And I agree with that to an extent, but for some providers, not broke means that the virus is undetectable. But to the patient, it still might be broken in the sense of intolerable side effects or difficult side effects or other issues with taking the medicine. And so communication between the patient and the provider is really important that way. It also goes exactly the opposite way too. Sometimes a patient will come into my practice who's on a regimen that I feel is very inconvenient and poorly tolerated, and the patient's like, this medicine saved my life and you're going to pry it out of my cold dead hand. You know, I'm not going to change. And so again, it's a matter of mutual respect and negotiation about working on those things. So let's proceed. So these 4 cases, again, are all people whose virus is controlled on treatment, whose HIV is controlled on treatment, and they have other medical issues that may or may not influence whether they stay on that treatment or change. Maybe I'll talk a little bit more about changing treatment before I talk about the cases. In HIV, now there's 2 main kinds of situations in which we might change somebody's treatment. One is if the antivirals, quote unquote, stop working. If somebody's taking them and yet the virus is starting to come back anyway. And usually that means either the virus has become resistant to part or all of their cocktails, usually a 3-drug cocktail, or the person is missing doses, which we call non-adherence or poor adherence, or often a combination of both, because lack of adherence of taking medicine every day as prescribed can lead to resistance by the virus. So that's one situation where you may need to change antiviral therapy. That's not that common, especially in my practice, which is a fairly kind of middle class on average. I mean, I have the whole spectrum, right, from homeless to wealthy, but most of them fall in the middle. And most of my patients are pretty good about taking their meds adherently enough that they don't experience failure. And also the meds are better, so in general, the meds are a little more resilient. It still can happen. But much more commonly, the reason that we change therapy is due to other factors. So somebody is continuing to have successful antiviral treatment, but there's some other factor that might lead you to want to change medicine, such as making the regimen simpler, so fewer pills instead of more pills. We have a lot now of fixed-dose combinations in HIV, where we have 2 or even 3 or even 4 drugs in one pill, making it easier for the patient to take their medicine. They don't have to, and actually there's a lot of other reasons. There's cost reasons. There's 1 copay or 2 instead of 3 or 4. So simplification, side effects, which are actually the most common reason people switch. And many HIV medicines have sort of signature side effects. The newer ones are much freer of side effects, to the point that for a lot of folks, when I'm describing what their choices are for treatment when they're just starting and they want to know what the side effects are, I'm sort of hard put to tell them anything, which is a little bit of a challenge because it impairs my credibility if I just say, oh, this has no side effects. So I kind of need to say something, but they're much better now than they used to be. So side effects, simplification, again, co-pays, cost. Unfortunately, the whole third-party payer situation and the cost, these meds are expensive, right? So the cost of an antiviral cocktail is somewhere between $1,500 and maybe $2,500 a month, the retail cost. And more insurers are sort of adding more cost sharing. And for the past few years, for the first time, I've had patients come in off their meds because they couldn't afford their co-pays. So cost can be an issue. Unfortunately, sometimes cost leads us to change meds, which we'd rather be purists and give the person whatever is the best for them medically. So there's multiple reasons people might change their regimen. And sometimes patients are reluctant in the sense that they have heard from the past that if you go off a certain HIV drug, you can't go back on because it won't work the second time. And that's a misconception based on resistance. And that goes back to the first reason we switch, and we used to switch more. People used to fail more with a resistant virus, and in that case, that's true. They can't go back. But if your virus is suppressed, if you're on HIV and the meds are working and you switch, you can go back. There's what I call no penalty for switching. So that's a patient education piece that I do because I'm always not wanting my patients to be on medicine that makes them sick. There's a lot of psychosocial overlay to HIV as well, and there are some people who it's almost masochistic. They almost feel like the side effect is their punishment for getting HIV, and that they don't deserve to not have side effects from their meds. And so sometimes we have to overcome that to, no, you don't have to have diarrhea every day. You can like have a more normal life, and it's okay. You're still an okay person. HIV doesn't mean you're a bad person or wrong. So let's talk about the cases. And I think I'm just going to go through them in order. Well, let me tell you what the 4 are. And if anybody has like a strong feeling that you want to hear about one, we can do it. And otherwise, I'll maybe just go through them in order. The first is a 58-year-old woman who has hepatitis C as well as HIV and is on methadone. And she's on a protease inhibitor cocktail of Truvada, atazanavir, ritonavir. So she's on a 3-drug, a 3-pill cocktail. Then a 51-year-old male with hypertension and erectile dysfunction, and he's on a pill called Stribild, which is an integrase inhibitor pill that's in the whole cocktail's in one pill. The third is a 42-year-old man with hypertension and renal insufficiency, and he is on Truvada and raltegravir, which is another integrase inhibitor. And then the fourth is a 30-year-old overweight diabetic male who's also on Truvada and raltegravir. So any requests, or shall I just sort of go through them linearly and we can talk about what the issues are?
They're all undetectable.
They're all undetectable, and they all have, I made this little note to myself, they all have wild-type virus, means they have no mutations, so that the virus has no mutations, so that they're eligible for any therapy from a virologic point of view.
Well, before that, how do you know that? What's the initial approach then? If someone comes in with newly diagnosed HIV, can you talk a little bit about
Sure.
how you select one drug over another, and where does resistance assay come into the initial?
Yeah, definitely. So the deal with HIV is that if somebody is infected with HIV and develops resistance due to exposure to meds and viral breakthrough, they can transmit that resistant virus to another person, the usual way, sexually or needle sharing or whatever. And so a person can come in newly diagnosed with HIV and have a virus that's actually already resistant to some of the meds we would normally use. And so it's kind of analogous to somebody with a urinary tract infection where you want to know what that E. coli is susceptible to before you just give them an antibiotic, ideally. And similar with HIV. And the rate of what we call transmitted resistance, it varies geographically. Seattle, unfortunately, is kind of a champ. We have about 20% of new infections are resistant to one or more classes of HIV drugs. So it's very important, and it's standard of care when somebody's newly infected to do a resistance profile on their virus. And then that will tell you, it usually looks at the 3 common classes of drugs historically that we use, which are nucleosides, non-nucleosides, and protease inhibitors. We have a resistance assay now for integrase inhibitors, which are, again, the class that is sort of the up-and-coming. It's not universally used yet because integrase inhibitors haven't been around long enough to generate that much community resistance, but people are starting to see transmitted resistance to integrase inhibitors. So I think in a few years that will be a standard thing to do as well. So yeah, so we do, when somebody comes in newly diagnosed, we do several things lab-wise. We do a viral load, which says how much HIV is in the bloodstream. We do a CD4 count, which is the measure of their immune function, and we do this resistance profile. For the HIV, those are the things we do. Our guidelines used to tell us that we should wait until people were sick to a certain degree before starting meds. And that's kind of counterintuitive, and there's more and more evidence for various reasons building up that there is no one who's not eligible for treatment who has HIV. If you have HIV, treatment is indicated. And that actually makes it simpler because you don't have to parse to the person, oh, you're not sick enough yet, your T cells aren't low enough, or your viral load's not high enough, because we know probably that any amount of virus is actually bad in other ways for people. The other reason that it's important is because of transmission. People who are viremic with HIV, who have uncontrolled HIV, transmit the virus. People who have fully suppressed HIV on meds are very unlikely to transmit virus. And this is new information that's unfolding in the last few years. And it's important in terms of mother-to-child transmission, which we've been aware of for a long time, but also sexual transmission of HIV. There are 2 studies now that are longitudinal studies of serodiscordant couples, couples where one's positive, one's negative. And these are both gay couples and heterosexual couples who are having unprotected intercourse on an ongoing basis. And in both of these studies, now 2-3 years in, they've seen no transmission to the negative partner despite exposure to the positive partner in the situation where the positive partner has undetectable virus. So there's strong reasons to treat. That latter reason is really a public health reason, right? Because there's theoretical calculations that if you can treat 80% or more, X% of the positive people in a population, you will reduce the rate of increase of new infections. And so treatment as prevention is kind of the buzzword for that. So we do this assessment, but it doesn't influence whether we treat. It might influence what we treat with. And that can be based on resistance, and it can also be based on the patient's other situation. It can be based on their comorbidities. If you look at these cases, this is representative in the sense that our HIV population is diverse, and half of them are over 50 now. So a lot of our folks that are over 50 have other issues like diabetes and other things. A lot of our HIV patients are co-infected with hepatitis C. They may have social issues, mental health issues. These all influence what meds we would use. We have guidelines from DHHS, which are fabulous, and if anybody's interested in something that will help you fall asleep at night, there's like a 150-page guideline that you can download if you just Google DHHS HIV guidelines. And over time, these guidelines have become more and more evidence-based. They're actually very evidence-based now. When I talk to trainees, they're all about evidence-based. Why are you doing this? And the guidelines are really good that way. They cite the references, and they give the degree of evidence, how strong the evidence is. And the guidelines have information about what regimens are the best to start with, or the most recommended to start with, as well as a lot of other information about the paradigm for switching therapy in somebody who's undetectable and why and how one might do that safely and what would be the advantages and disadvantages, and a lot of other stuff. So it's actually a great teaching tool. Guidelines are just guidelines. They're not rules. And I was just in a meeting actually last week. We were discussing the role of the guidelines, and you know, some providers are almost fearful that if they prescribe something that's not the most recommended in the guidelines, that they're liable for not living up to a community standard or something. But the truth is the guidelines are just telling us what has the best evidence. And there are certainly treatments that are not the most recommended in the guidelines that still may be the best regimen for that person. The current guidelines were changed radically about a month ago. The guidelines from last year had 11 different cocktails that they felt were all the topmost evidence of ways you could start treatment for a patient. And the most recent guidelines cut those 11 down to 5 and eliminated almost everything but integrase inhibitors as recommended starting regimens. And that's because of the best evidence as far as efficacy and tolerability. So now we have 4 integrase regimens and 1 protease inhibitor regimen, which are the most recommended. I don't completely agree with those guidelines because there's other classes, there's non-nucleosides, and there's other regimens that for some patients I feel would be appropriate and useful. But we have guidelines. Guidelines are great teaching tools, and I have residents rotate through my office, and I always make them look at the guidelines. The other thing that I do is somebody who's newly diagnosed, if it's not really urgent that they be treated right away, the community mentality now is if somebody's diagnosed with HIV, at least in Seattle where I see folks, they get tested, they come into our clinic, their agenda is, I want to start on treatment. But I don't like to prescribe it the first visit because I don't really know that person very well. I don't know if they're ever going to show up again. I don't know that much about their life, about their other medical conditions. So it takes 1 or 2 visits of getting to know them and doing a sort of more global assessment about all of their medical situation, their social situation. And then the next visit or the one after that is when we would pull the trigger and actually get started on medicine. Unless they're desperately ill with advanced HIV, and that's different. We know that starting treatment right away is helpful in that situation. And then there's the pharmaceutical companies have these posters. I don't know if Merck has, but there's this poster which has like all 30 drugs for HIV. I don't like to show that to patients. I actually use it for teaching with residents, but the patient looks at that and their eyes just like bug out. And the truth is that a lot of those drugs we don't use anymore anyway, but they have to put them all on there for like legal reasons. Like I said, the guidelines narrow it down a lot, but there's also research that if you give somebody too many choices, it impairs their ability to make a decision. So like we have like 7 ACE inhibitors, right? But if I'm prescribing an ACE inhibitor for somebody with hypertension, I don't tell them, you know, here's the 7, you pick one, and they pick the one that has like the name they can pronounce or whatever. That's not really necessary. On the other hand, in HIV or in anything, for me, my dialogue with the patient isn't, I've chosen this for you, here it is. I like to give them 2 or 3 choices, and I like to have them participate in the decision making. So in my exam room, I actually have a shot glass with pills, with real pills, which are the HIV meds, and we actually put the pills on the table and look at them, and I tell them you could do, and I like to give people either just 2 or 3 choices, no more than 3, and sometimes just 2. You could do this or you could do this. And again, with HIV, a lot of our pills actually contain more than one agent. So I explain to the patient, this pill contains this, this, and this. And so that's the dialogue. With HIV, we have now 4 regimens that are the entire treatment in 1 pill once a day. And so that's a very sexy thing for people. A lot of people, they've heard of that or they have friends that are on something like that, and that's almost their expectation of which one pill once a day are you going to give me, right? So, if you look in the guidelines, the 5 recommended regimens, only I think 2 of them are like that. So the other 3 are as separate pills. And that may be the best thing for a given person. So some education is involved, and often, sometimes it's like you could do this 1 pill once a day or this 1 pill once a day, but sometimes it's like you could do this pill or these 2 pills or these 3 pills. It's generally once a day, but sometimes twice a day. One of the 5 recommended regimens, which is the raltegravir regimen, is twice a day. And that some of that depends on the patient's other situation, their ability to take meds once a day or twice a day. If I'm seeing a 21-year-old college student, which was actually my last new HIV positive patient, was a 21-year-old college student who was like very remorseful, but that's another story. A single pill once a day is probably easier if that person is completely healthy, and especially males. Males in their 20s, they don't see doctors. They have no reason to see a doctor, and they don't get it, like taking medicine. They're a really hard group for me to work with as far as adherence, and often their HIV medicine is their only medicine. In that group, a single pill that you can take in a simple way is probably the best bet. On the other hand, there's like a diabetic, for example, that might be on metformin, which is twice a day no matter what, and that's the mainstay of type 2 diabetes, is the drug we're supposed to always start with if we possibly can. They're already on a twice-a-day drug. So then the idea that, well, your HIV medicine might also be twice a day, that's not a big deal for them. So it's all about context. We also have data in HIV that folks over 50, so in HIV, over 50 is old, under 50 is young. I don't know how it is in other areas, but that's kind of the divider in HIV. But we know that folks over 50 with HIV actually are better at taking meds and actually have better treatment success, which is good because if they're not treated, they also progress faster and get sicker faster, which kind of makes sense. The immune system ages, and HIV is worse for people that are older. But older people are better at taking meds, and it's not such a big deal whether it's 1 pill or not. So anyway, that's how we get started.
Back to the patients.
Yeah, well, another thing I tell patients, which does go back to the patients, is because sometimes people get kind of like paralyzed by indecision, and they feel that whatever treatment they pick to start their HIV is like the most important decision in their life, and they don't want to blow it, and they don't want to get it wrong. And I tell them that's not really true, right? You can start it, and it doesn't work out, we can switch. And again, no penalty for switching. And there's data that more than half of people, this is a few years old, I don't know if it's still true, but more than half of people starting treatment for HIV switch to something else within the first year. And it's really more common than you would imagine. I think this pill's the wrong color. Do you have something else that might be blue instead of pink? Not like that, but side effects, co-pays, whatever. So let's do cases. So why don't I talk about the diabetic, just because I mentioned diabetes. He's a little atypical because he's only 30, type 2 diabetic, but that's actually more common now. As you know, we have an epidemic of type 2 diabetes in this country related really to lifestyle issues. So we have a lot of people with diabetes. And with HIV and diabetes don't really perform very well together because the toxicities overlap and the meds can interact. And but we see a lot of folks with HIV who have diabetes. So one of the issues for both HIV and diabetes is renal concerns. Diabetes is a risk for kidney problems, so is HIV. And some of the meds that we use the most commonly for HIV also have renal concerns. They're either cleared by the kidneys, potentially injure the kidneys, or both. And so in HIV care, I think I probably spend more time worrying about somebody's kidneys than I do worrying about somebody's liver, which is kind of interesting because in a lot of situations, liver toxicity is a bigger issue from meds. But in HIV, kidney is a big issue. So he's got type 2 diabetes, and he's on Truvada, raltegravir. So Truvada is once a day, raltegravir is twice a day. He's also on metformin, which is twice a day. So from that point of view, there is no big downside to him as far as adherence to a twice-a-day HIV regimen. And the question is, and let me just see if the case says, take too much. Actually, let me just see if there's anything else about him that I want to tell you. His CD4 count is fine. His virus is suppressed. These are all people with suppressed virus. And the question is whether he should maintain or switch his regimen. So from my point of view, it's kind of really up to him. I think that there's no long-term concern with him staying on this. He may want to be on a 1 pill once a day, but again, being on metformin, that's not a big deal right now. His kidney function's fine right now, so he could take any of the recommended regimens. But let's just say, for whatever reason, that he wants to be on a 1 pill once a day. Let's just say that he feels like he would do better with 1 pill once a day. He could do any of the 4 that we have that are 1 pill once a day. So that would be Stribild, Complera, and then I'm going to Triumec is the 3rd one. Maybe there's just 3. Oh, and Atripla. Forget about Atripla. Atripla was the granddaddy of them. So he could do any of them. They all have different potential side effects. So I would talk to him about that. Stribild can have GI side effects. What he's on now doesn't necessarily have that. Atripla, we seldom newly prescribe Atripla anymore. Maybe I'll talk a little bit about that. Atripla is a fabulous drug. It was a pioneering drug. It was the first time we had the whole cocktail in 1 pill. It's Truvada plus efavirenz, which is a non-nucleoside. It came out, I think, in 07 or 08, and it was, from a psychological point of view, it was huge because, especially for folks that had been HIV positive for a long time and were used to taking these complex cocktails of pills, to take all their medicine in 1 pill was, from a self-esteem point of view, an ego, like how sick and infected and contaminated I am. It really made a big difference psychologically for people that they could do the whole thing in 1 pill. And there's really good data for efavirenz that it's a very, very good antiviral. It's been almost unsurpassed. We now have some regimens that surpass it. The issue with efavirenz is tolerability. Efavirenz has central nervous system side effects of dizziness, vivid dreams, sometimes foggy thinking. And personally, in my practice, because I take care of a lot of techie people, they do not tolerate efavirenz because it impairs their work performance. So I never used it a lot, but I had a lot of demand for it because of the 1 pill situation. There's also data with efavirenz about suicidality, and the rate of suicide on efavirenz-containing regimens is about twice what it is on other regimens. And so it's small, but it's statistically significant. And so in the latest guidelines, Atripla was demoted from a preferred to a 2nd line choice. And so a lot of us doing HIV care, we have large cadres of people on Atripla. Maybe I have fewer, but I still have a lot. If they're tolerating it and doing fine, that's fine. But we seldom would start somebody on it new.
Less expensive than some of the others?
It is. And so the kind of hierarchy, it tends to be that each new drug costs about $200 a month more than the last one, each new of the single tablets. So Atripla is the least expensive, and then I think Stribild is the most expensive. So sometimes our choices are influenced by insurance companies. I'll have the conversation with the patient and we'll say, oh, we'll decide, oh, Stribild is what we want to do. And then the insurance company says, there's 3 other choices and they're not Stribild. And then we go back and discuss that. And I don't fight that hard because I don't think that it makes that much difference. And often the patient ends up going on what the insurance company wants them to go on, and they do fine. Or they don't, and then we go back and dispute it, and usually they'll say yes. So this person could switch to a once-a-day regimen, and I think that would be fine. Let me talk about the process of switching, because that's really kind of the key of this whole presentation, I think, is switching. The guidelines now have a full discussion of how to switch a regimen that's working and how to do it safely and what the principles are. And the principles are, first of all, why would you do it? You do it, again, because of side effects, convenience, tolerability. It's not because it's not working, right? But these other reasons, adherence, cost, and they list cost as a reason to switch. Again, if somebody's on something with a higher copay, someone with lower copay. But the paramount goal of switching is to not lose control of the virus. That would be a real no-no. And we have a few studies in HIV that tell us what not to do. We learn more from a failed study than a study that works, because everything that works is like, it worked, but do you really know why it worked? But if it fails, you can kind of analyze what not to do. So we have some studies of switching that show us what not to do. And what not to do is switch to something where you're not controlling, where you're predicting to not control the virus quite as well as before. So if somebody's got wild-type virus, that's a no-brainer. But if somebody's got a virus that's already resistant to a few drugs, you have to really know that the new regimen is going to be equally effective as the old one. And so at least one of the switching studies didn't take that into account, and as a result there was an excess of virologic failure in the people who switched. And I actually do lose sleep. I'll tell you a story. I haven't told enough stories about my practice, so I'll tell you a story. So I have a long-term patient with a virus that's resistant to a lot of stuff, and he's on a kind of what I call a Baroque cocktail for HIV, right? It's like different times of day and multiple pills, but he controlled his virus finally, and it's really good. And we saw him through his whole career as a TSA agent, don't hold that against him, and now he's retired. But he started having vision problems, and he lives like 100 miles south of Seattle. And so he went to OHSU with these vision problems, and it turned out that one of his HIV medicines was crystallizing in his retina, which I had never heard of. So he had this thing called ritonavir retinal toxicity, which has been reported in a grand total of maybe 12 patients. And this ophthalmology professor at OHSU was fabulous. He sent me a letter, and he actually sent me like a reprint of the article describing what my patient had. So he had to go off ritonavir. And that's hard because we use ritonavir a lot to boost other HIV drugs, and it's hard to construct for somebody with a resistant virus. A cocktail doesn't contain ritonavir. And so, but we kind of did it, and I was a little uneasy about what I was switching him to. But this was a serious vision impairment. He could not read, and if you can imagine, you can see well enough to, I can see all you folks, but not read, that would be devastating, right? So, but we jiggled things around and got him onto something that looked like it would kind of work, hopefully. There was like a lot of body English in that, and his virus had been suppressed. So he came back a month later, and he had a detectable viral load. That was not huge, but it was detectable and been undetectable a long time. And I actually did lose sleep. I woke up in the middle of the night like, did I ruin it for this guy? But you're kind of stuck, blind or AIDS, it's hard. So we got him back again in 2 weeks, and the virus was undetectable. And then again 2 months later, and it's still undetectable. So knock wood, it worked, and I'm sort of holding my breath. But now it's been long enough that I think it did work, and I'm not sure why he had that. We call it a blip. Sometimes people get a little virus. And then the really good part is that these crystal things in his retina are dissolving. He had his follow-up with the ophthalmologist, and it was only like a month after he'd been off ritonavir, and he had a lot of improvement. And the last time I saw him, he was starting to be able to focus enough to read again. So And that's kind of delicate dance, and that's a really kind of advanced switching scenario. Compared to switching people who are well suppressed, that's the kind of case where somebody with that kind of condition should really see an experienced HIV provider. A lot of primary care folks can do basic HIV care really well, and I'm a strong advocate of that. The patients need to have wild-type virus, or should have wild-type virus, and maybe not be too complicated, but then we have enough guidance and enough good regimens for folks that I think any primary care provider should be able to do the basics of HIV. But if somebody's advanced, they have a resistant virus, they've had quote-unquote full-blown AIDS, and they have a complication, that's where a consultation with an HIV specialist is really important. And I call colleagues call me, we discuss these more complicated cases. And that's an example of squeaking through and not having the virus come back. And fortunately, I have never had a situation where I switched somebody and they failed, but it could certainly happen, and I don't want that. So this guy has choices, and he could switch or not, and I would really kind of have that discussion with him, and I would be fine about him switching. Let's maybe talk about the first one, just because she's a more complicated. Yeah.
Can I ask just one
Sure.
complicated question? But, you know, a few years ago I was kind of involved in this, but the issue was that I was at a lecture with Spock, and he was worried even at that time that which, you know, what was it, 65,000 people a year at a minimum were being diagnosed. With the cost of these drugs, Ryan White was running out in 6 months out of money. Where are we going? I mean, and there was always that worry 6 or 7 years ago that we were going to get to a point because we're becoming more efficient, we were treating people way earlier for good reason, that the money was just going to run out. And I mean, where are we going with that? I mean, the cost of drugs?
Yeah, I don't know. I mean, because I'm not that up on like the public health and the health economics of it. I mean, so far it's working, but you're right in the sense of we're seeing more cost sharing, and I don't know if that's because the system is kind of straining or because the insurance companies are getting, you know, sort of more. Cost sharing is when the patient has to pay more out of their pocket. We're definitely seeing that. But I think one partial way out is obviously generics. And by 2020, we'll have enough generics that at least for a portion of our population, we could be treating them with generics. We almost have it now, but part of as I was saying earlier, we keep getting new drugs that are better than the old drugs, and so like ATRIPLA is a good example of that. Was the standard for so long, and in a few years the components will be generic, but by then we will have moved beyond it. And so then the question is, are there going to be people who are taking something that's not really as good, maybe, or because it's cheap? And that may happen. That
When you
may
say
really happen.
when ATRIPLA, I didn't interrupt you, but
Yeah.
ATRIPLA is cheaper. Like, I mean, it's still, when I look it up on my pocket,
Oh,
it's still $2,000.
Yeah, exactly.
So it's not like it's 500 the other. So there's not much difference, right?
There's not much difference now, and the difference is that there's, like I said, it's like about a $200 difference between each one, and so we have some insurance companies that are like, if we try to do Stribild, they'll say, why can't you do ATRIPLA? The difference between Stribild and ATRIPLA is several $100s a month. The other thing that's going to happen, I think, is we have these fixed dose combination pills like ATRIPLA, and part of ATRIPLA will be generic before the other part, and so we may see the insurance companies say, you know what, is it that necessary to do it all in one pill, or could you do like generic efavirenz plus branded and save, you know, $1,000 a month or so? Depends on how cheap the generics are. There's a drug that we seldom start people on anymore, but I used it a lot in the old days, called nevirapine, which is a non-nuke that was before efavirenz, and I liked it a lot because it didn't have the CNS side effects of efavirenz, and I still have a lot of people on it. The cost of nevirapine now is $20 for a month's supply, generic. So ultimately, I think that'll be the solution, but that'll be a ways yet. We right now have ways, sorry?
You send patients to Canada?
Yeah, it's not that cheaper in Canada. I've had a few patients get quote-unquote Canadian atripla, but they don't have generic atripla. But what happens is the Canadian pharmacy gets Indian atripla, and then they resell it to, and in most of the resource-limited world, atripla is the standard now, because the Indian company is making generic atripla, which is not illegal. I mean, it's like a licensed generic. So. Cool, good questions, and this is what I was hoping this would be. Since we don't have slides and I don't have like a thing to feed you folks, it's good to sort of hear what you're interested in. Yeah.
Well, we're off schedule.
It's okay, hey,
Let's keep
Would
going.
you-
No agenda.
No, the developing world.
Yeah.
When they first started treating HIV in sub-Saharan Africa especially, there was no fantasy about keeping people healthy for a long time. It was all, 2 or 3 years, get the kids raised, get a little bit of money in the, there were a lot of goals, but they were not.
Right.
Has that changed with these drugs? Are they now have access to longer term?
It has, but the access is still really poor, and the whole thing, everything is so different because the infrastructure is different and the budgets are different, and so on the one hand, you could provide enough drug for everybody, but you don't have the infrastructure to deliver it or to do the monitoring. So a lot of what happens in a lot of countries is they don't have the luxury of doing T cells, viral load, never do resistance testing. So they do it all kind of blindly. So at most, if they do anything, they do T cell counts. So somebody would start on like generic atripla, and if they're doing okay, no monitoring. And then if they start to get sick or they get a T cell count and it's lower, or even just like a lymphocyte count, which is cheaper yet, and it starts to flag, then they switch to a protease regimen. So there's like a standard thing that you do without knowing as much as we do. And then there's a lot of triage. So the WHO guideline now for treating HIV in resource-limited countries is CD4 under 500. It used to be under 350. But there's so much good data that there's a health benefit. But that doesn't mean everybody under 500 in these countries gets treatment. So it's the first triage is pregnant women to try to, because if the woman has a suppressed virus, then she's less likely to transmit to the baby, much less likely. And that's the mode of transmission they want to attack first. But there's some recent studies now. Again, the studies that show that sexual transmission is so greatly reduced if somebody's virus is suppressed. So that's another sort of motivator. So couples that are serodiscordant are another target now of treatment to prevent transmission to the negative partner. And there's a lot of interest in doing pre-exposure prophylaxis in resource-limited countries to try to stem the epidemic. The studies of using Truvada, a pill daily for PrEP, it does better in a Western country than in a more resource-limited country where people may give their medicine to someone who's sick and whatever. There's a lot of reasons for that, less adherence, but there's a couple drugs in development that would be every month, every 2 months, every 3-month injection for prevention. And if that works, that would be a huge step in stemming transmission in these countries, because you don't have to deal with the whole supply issue of getting a bottle of pills and taking the pill every day. People go to a health center, get their shot. That'd be it.
But circumcision for prophylaxis.
It's another, so male circumcision for prophylaxis is also another proven method, and there's various techniques of going out in the field and doing that in a mass way, and so there's a lot of different approaches to try to reduce the epidemic. I think they're starting to have an impact, but I haven't seen a huge impact yet. And I mean, I'll give you an example in Seattle where we're really good at treating people, and we have, I don't know, something like 80% of the HIV population in Seattle is treated and has undetectable viral load, which you would hope would reduce new cases, but yet the health department sends out their monthly statistics, and like so far in 2015, we're we have more cases than we did in 2014. So it's small numbers. It's like 80 versus 60, but it's still a little discouraging that it's not like 10. And we're doing a lot of prep too. We're prescribing a lot of pre-exposure prophylaxis for people at risk. Try to reduce that.
But you're a target community for people to move into also.
Yeah.
I don't know what are you really measuring with your statistics?
Yeah, you're right. And these are not necessarily all homegrown cases at all. You're right. That's true. For various reasons, yeah.
So, maybe you're on 72, but I've got several patients that their viral load bounce around. They used to be around a couple of detectable above 200, and that's changed now in our assays to less than 20. So I have a viremia at 38 or 52 or whatever. And I can't get a straight answer when you even talk to my mentors about, well, what point do you call it failure? Your CD4 is behind, the viral load, they all happen sometimes up to a year in a row with viral load at 38 or 52. And patients realize to change the regimen, and I don't have a real good reason to, other than it bothers me having a viral load.
Yeah. I think that may be more an assay of the test, and a problem with the test than a real medical problem. And yeah, I would do like you and not change the regimen. It's pretty clear that this quote-unquote low-level viremia, first of all, changing the regimen usually doesn't change that. They still bounce around like that. And some of that may be biological. There's some correlation between those little bits of virus and how big of a reservoir of HIV the person has. And, you know, a few of these latent CD4 cells get activated and they spew out a little virus. The patient may be doing nothing wrong. They may be taking their meds every day. So I have folks like that, and I tolerate it. Certainly if they're under 50, I don't worry. If they're between 50 and 200, I worry a little bit about adherence. I think some folks are less adherent than we think they are, and they come in and their viral load's undetectable, and so they're like, they don't. I had an example of a patient who I thought was perfectly adherent, always undetectable, and then the note comes back from the orthopedist that says, you know, he's got HIV, he's on such and such meds, which he takes every day except Sunday because Sunday's his day of rest, and like, he never told me that. So some of it might be that, but yeah, if it's not going up, and if it's like in the 2 digits, I wouldn't sweat it.
I had a patient for a long time who would only take her medicines in the week before her assay was going to be drawn.
Really?
And she said, I mean, this is a long time ago, and the side effects were such that, you know, she was raising a small child and said, you know, yeah, the side effects are just too much.
Yeah.
So she's still alive now, thanks to the new
It's a
medicine.
miracle. It's cool.
So yeah, it's always important to sort of listen to that with a jaundiced ear, I think.
Yeah, sometimes, or the other thing that I hear sometimes from pharmacies is like, person's on 3 drugs, but they only need to refill 2 of them. It's like, what are they taking that they're not out of that one yet, you know? Oh, okay. It's amazing the meds work as well as they do, considering. So, you know, and again, in a few years we may have injectable treatment, which would be sort of automatic adherence, and that may change things a lot. There's a lot of effort into both treatment and prevention through injectable ARVs, which have a lot of technological hurdles, but if that worked out, that would be kind of a paradigm shift.
Time released or long acting?
Both. So like, for example, the cabotegravir is just an example. So it's integrase inhibitor. It's analog of dolutegravir, not quite the same. It has an extremely long half-life, for one thing, but the formulation is also part of it. So far, the ones I know of, cabotegravir and rilpivirine, it's not like they're encapsulated special, but they're microcrystalline, which apparently dissolves at a slower rate. So slower rate of dissolution plus a long half-life. Cabotegravir is kind of fascinating because in the initial studies in healthy volunteers, they had volunteers that got one IM injection of cabotegravir who had detectable drug after a year. So there's good and bad to that, because if somebody has a side effect or a toxicity and the drug's in their system. But yeah, so I think that's kind of an avid area now of future research is depot antiretrovirals and other kind of injectables. It's 8:30 and I don't want to run over, so the main thing I want to do is like really thank you folks for your questions and helping this be like a good free-form discussion. So
Tell us about the hepatitis C patient.
yeah, I can do that real quick. So this particular person, the way the case is presented is she's a genotype 1A, which is genotype 1 is the most common, and she's got stage 1 fibrosis, so it's not that advanced. And talking about the health economics again, we were hoping with these great new Hep C drugs that work for everybody that we could treat everybody, and it turns out because of the cost there's triage going on. And so she's really not sick enough that most insurance companies would cover her Hep C. The question is, should we change her meds? Sometimes we change meds proactively so that when somebody can be treated, their HIV meds aren't going to interact with their Hep C meds. So the regimen that she's on Truvada and Zanavir ritonavir. That's a reasonable regimen. It's actually a regimen that more women are on. She's 58, but younger women, it's one of the regimens that is kind of blessed by guidelines for women of childbearing potential. And the folks that take care of a lot of women of that demographic like this regimen. So maybe she's been on it for that reason in the past. Then you would wonder, is it going to interact with future Hep C meds? And actually, it wouldn't with the two treatments that are currently available, the two really good treatments are currently available. So the Bicara Pack, which is the Abbott Pack combination thing, it has ritonavir in it. I gave a talk yesterday actually to a group of women with HIV, and one of them is on it. And she was on this actually. So there's ritonavir in her cocktail, and there's ritonavir in the Hep C cocktail, and you just don't take one of them. So during the period she's on Bicara, she's not taking the ritonavir. So that would work. And then the other one, Harvoni, which is a two-drug fixed-dose combination, would also be okay. The issue with Harvoni is that it raises tenofovir levels. So there's a little bit concern, and it's interesting because they come from the same company, but there's a little bit concern of treating somebody with Harvoni who's also on Truvada. They're not contraindicated, but the recommendation is at least to monitor renal function. And I have a few people right now that are actually on that. They're on a Truvada HIV regimen, and they're taking Harvoni. We're watching their kidney function, and so far they're doing okay. But ideally, for me, if I have a patient with Hep C who also has HIV, I at least consider the Hep C when I'm going to treat their HIV, as mostly in terms of what I'm going to use for their Hep C treatment. There's no HIV regimen that's worse for your liver when you have Hep C than another one. So that's a misconception. It's like, what's like the most liver-friendly HIV regimen? Most of them have been studied in people that are co-infected with Hep C, and there really isn't a hazard there, or an excess hazard.
Do you, when you have women who want to have children who have good viral suppression, do you encourage them to go ahead and have children, or?
Yeah, and that's been like the most amazing thing, you know, especially if they were infected in the old days when they were absolutely told not to have children and it was bad, and if they got pregnant, they were being irresponsible. Now it's like intentional. Cool. Thanks.
Yeah, this is wonderful.